Hi, everyone. I am thrilled to be joining you this afternoon in the post-bac seminar series. My name is Megan Zimmer, and I am a post-bac cancer research training award fellow at the National Cancer Institute. In this talk, I'll focus on several projects related to dietary assessment in pediatric populations that I am excited to be contributing to during my fellowship. To kick us off, I wanted to start by orienting you to the risk factor assessment branch, or RFAB, as I will refer to it as. I think this is really central to understanding what I do and why I do it. So I work in the risk factor assessment branch under the mentorship of Dr. Joe Reedy. In our branch, we focus on modifiable risk factors for cancer. So that includes diet, physical activity, and as of more recently, sleep. Our branch is composed primarily of nutritional epidemiologists and physical activity epidemiologists, and we are within the epidemiology and genomics research program. All of this falls under the umbrella of the Division of Cancer Control and Population Sciences, or DCCPS. This is important because DCCPS is an extramural division. I anticipate that many of you in the audience may be intramural research fellows that are within intramural divisions and might be a little bit less familiar with what it means to be in an extramural division. As an extramural division, we are basically a public-facing division, so a lot of our efforts are focused on engaging with that extramural research community. So for example, our program directors don't apply to their own grants, rather they work in grants management. And as a fellow, I do not report to a PI that does their own independent research. Instead, I report to our branch chief. I do some research, so about 25% of my time is spent in independent investigations, but I do lots of other things too. About half of my work hours are spent in tool maintenance, and the remaining portion of my time is spent in extramural engagement. And I'll talk more about what each of those two things mean. But with that being said, this talk is going to be a little bit different than those you might be accustomed to hearing in the seminar series, because it won't be a traditional research spiel. So now that I have oriented you to the risk factor assessment branch, the rest of this talk is going to focus on the first two circles that you see up on this screen, and that's tool maintenance and extramural engagement. So I mentioned that about half of my time is spent in tool maintenance, so I'll talk about that one first. This slide will give you an overview of all the dietary assessment tools that the risk factor assessment branch develops and maintains. And we use the word tools broadly, so tools can refer to tools for data collection, meaning tools that are used to actually collect information about an individual's dietary intake. But tools also refers to measures and methods used in data analysis. So these are techniques for actually analyzing that dietary intake data. And all of this is really tightly intertwined with databases. So I want to quickly just walk through a high-level example, because I know most of you in the audience are not in the nutrition field. So as sort of an example, if a researcher was interested in investigating the relationship between dietary quality and some outcome, like cancer survivorship, one of the first things they might do is collect information about their patients and their participants' dietary intake. So they might use a tool called ASA24, or the Automated Self-Administered 24-Hour Assessment Tool. This tool is a web-based tool that can be used on a computer or a phone that collects information about what an individual is eating over a 24-hour time period. So this could either be a previous 24-hour time period, meaning a recall, or it can be a continuous 24-hour time period going forward in time, meaning an ongoing food record. And ultimately, the information that the participant reports about their foods and beverages gets merged with a database so it can spit out information to a researcher about what their actual nutrient adequacy is. But sometimes, depending on the research question, it's really helpful to just have a single overall score for diet quality. And something like the Healthy Eating Index is a great tool to actually get to that single score, because then that single score can be put into a regression model or used as a covariate in any other statistical analyses. The Healthy Eating Index is also a really great tool if you're interested in looking at overall diet quality rather than looking at just a single specific nutrient. So for the rest of this talk, I'm going to focus on the Healthy Eating Index because that's a tool that I spend a lot of time with. The Healthy Eating Index is a standardized measure of diet quality that's based on the dietary guidelines for Americans. So a high score reflects a dietary pattern that's aligned with our federal nutrition guidance. So as you can see on the right-hand side, that's the 2020 to 2025 Dietary Guidelines for Americans. And that's essentially the policy document that's prescribing the pattern that Americans should be eating. And then basically the Healthy Eating Index is measuring the extent to which Americans are actually complying with those guidelines. Currently, the HEI has only been validated for use in Americans aged 2 and older, and that's because the dietary guidelines have only been written for Americans 2 and older. But as you can see on the right-hand side, you do see some images of infants and toddlers on the cover image for the dietary guidelines, and that's because these new guidelines, for the very first time, actually included recommendations for this population. So now what we're working on doing is developing a version of the HEI that can be used in this pediatric population, this population from birth to 24 months of age. And so this slide kind of gives you an overview of how we have traditionally and historically gone about updating the HEI when a new version of the dietary guidelines is released, and it uses HEI 2015 as an example. So the first step is just to gather information from all of our stakeholders. That includes researchers that use the HEI in their own research, as well as our federal stakeholders and other content area experts like those that were on the Dietary Guidelines Advisory Committee. Once we've gathered all that information, we reflect on whether substantive changes need to be made to the Healthy Eating Index. One of the key guiding principles for that index is to only make changes if substantial changes are needed, meaning that there are actually changes to the dietary guidelines. And so I guess sort of a little spoiler alert is what we're finding right now for adults is that the dietary guidelines didn't really change all that much from the last iteration. So we don't expect releasing a new HEI for that older population. And instead, we're really focusing all of our efforts right now on kids. But I will still talk about the next step, which is validation, just because it's important for what I'll say on the next slide. If we make changes to the HEI, we then have to validate those changes and make sure that the index is still a valid tool. One of the ways that we might do this is to use the index in 2 populations with known differences in diet quality. So for example, smokers and non-smokers are known to have differences in diet quality in part due to the way that smoking suppresses appetite. And so we might use the tool in these 2 populations to see if it can really distinguish between the 2 of them. And then ultimately, once all of our analyses and validation work is done, we will release the HEI and several associated manuscripts. We also update our web pages and provide our code so that other researchers can use that code in their work. And so what we're doing right now is trying to take the same process that we've used for adults and sort of scale it down and apply it to kids. And there are lots of unique considerations with kids that have made this process a little bit challenging. So for example, in the validation work, we don't have a cross-sectional national data set that has all of the data pieces that we need for this young population. So we're still consulting with some of our stakeholders in that step 1, gather information, to determine if there are other data sets that we can use. And we're also exploring maybe shifting from traditional cross-sectional surveys towards more of epidemiologic cohort data, which would give us enough of the data pieces that we need. Another consideration is I talked about how we might validate this in the past with smokers versus non-smokers, but a lot of those comparison factors aren't super relevant to kids. Hopefully we don't have too many Americans under the age of 2 that are smoking. So we first really have to conduct some primary research to determine what the differences are that we could even be testing for in our validation work. So all to say that even though this looks like a really nice, clean process, it's hard. I mean, to develop a metric for a population where a measure hasn't previously existed is hard, but ultimately, as a research community, we do hard things and we do them for what matters. And dietary assessment in kids matters. Dietary habits in infancy and toddlerhood track into adulthood. And so establishing those adequate dietary patterns in those early developmental stages is really a protective factor against chronic disease across the life course. And so it's obviously really important for us to develop measures and ways to actually assess dietary intake and dietary quality in these pediatric populations. But equally important to that is engaging our extramural stakeholders along the way. So I'm now going to pivot to talk about extramural engagement and some of those activities that I do during my fellowship. Extramural engagement basically just means interacting with anyone that could use our tools or apply to our grants. And I have several examples listed up here. I'd say probably the most common are independent investigators, and that includes investigators here at the NIH in intramural divisions, but also academic investigators. We also collaborate really closely with other agencies within our Department of Health and Human Services, like the CDC, as well as other departments, like the Department of Agriculture. We collaborate with these different stakeholders in a variety of different ways, not limited to those that you see on the right-hand side of the screen, but those are just some examples. So for example, one way that we collaborate with academic investigators is to co-author manuscripts with them, especially when they're using our tools like the HEI. We also maintain web pages about the HEI, how to use it, and provide sample SAS code for researchers interested in using this tool. We also conduct user testing on those web pages to make sure that they are easily interpretable and have all the information that researchers are really looking for. And we do that using a combination of eye tracking and qualitative interviews. So that is sort of a little bit more research focused when we're doing that user testing. We also attend many national and international conferences. At these conferences, one of the things that we do is hold pre-conference workshops where we have just sort of a roadshow of all the tools that we have available, as well as tutorials on how to actually use those tools. But we also give traditional research presentations, so talks and posters that are focused on original independent research. Although I will say most of those independent investigations typically end up using the tools that we have here in our branch, so that hopefully it can be an example to the research community about how you might integrate some of these tools or use them in their own research. And so there's this famous quote, "When you know better, you do better." And we've been reflecting a lot on that in our branch about how it's sort of ultimately the crux of our mission as scientists and as researchers is to better understand how some phenomena is happening. But in order to be able to do that, we have to be able to measure that construct, whatever that phenomena of interest is. And so we've adapted sort of an alternative version to this quote that's really served as our guiding light. And that's when we measure better, we know better. Because then when we know better, then we can start to do better. But ultimately, we need to be able to measure a construct like infant diet quality before we can know better and before we can do better. So once we can measure it, that's when we can really begin to improve it. And so they say teamwork makes the dream work. So I want to encourage and thank everyone that's on our team here at the Risk Factor Assessment Branch, especially our branch chief and my mentor, Dr. Joe Reedy. And I think that we have some time for questions now, but I've also included my email address up here if you want to connect offline.